Number of treatments. Well, the textbook says 3. But guess what? If you only do 3, that means you would have only had 2 sessions of before and afters. And I can tell you this much, it takes a lot. I had a patient just before I came, and I can't remember what I did on her, but, oh yeah, right. It was retexturing her skin. So she's like, I noticed my skin's softer, but I'm not really seeing that much. So I had to explain, well, remember you only did 1 treatment. And this was her 3-week checkup. So I said to her, you're going to need to come back in a week, and we'll do it again. And that's when you'll see more change. And then after we do 3 treatments, you then should be able to see a big difference from when you started to where you are now. But if you notice, the guides are saying 4 to 6 for the majority. Why is it 4 to 6? Well, 3 and 3 would be 6. And why 4 instead of 3? Well, for good measure. Okay? Right? Let's look at number of treatments, and let's look at time between treatments. Why is it that I'm seeing everything here at 30? Why is this number 30? What's the skin cycle? 28 days. Why is it that I'm going to wait a skin cycle to retreat? Well, it takes time for these things to take place. Remember, these are natural treatments. Okay? You are using or stimulating your body's own regenerative capabilities. So you need to give your body time to actually do it. And the good, safe time is 1 month. It's easier to say to a client, come back next month than come back in 28 days. Right? It's easier. We'll notice that if we're dealing with deep wrinkles, that you may give a little bit more time. Why? Because you're doing more injury to the skin, deeper injury. We also notice that with hair regeneration, there's some times that you're giving it 40 days. Why is that? If you're treating scarring or scarring alopecia, you have a gentleman who has androgenic alopecia, and we're now going into that realm of scarring where it's thicker, harder, the blood supply is now extremely restricted. So what are we going to do? We're going to go deep and aggressive. We're going to try and break this up. And that's how, we would get it moving. So for that reason, you may need to give a little bit more time. But globally, that's the explanation as to why we're doing it at 30 days between. Let's talk about acne. Now, when you're going to treat acne, are we going to microneedle active acne? No. Why? Because you're now going to be, potentiating this spread of infection, right? So when we're saying acne treatments, we're more concerned with acne-prone skin rather than a patient who's coming in with a crisis of acne. So if the patient is coming in with a crisis of acne, we would first need to resolve the crisis, and then we can progress to treating the acne-prone skin, where we would be able to decrease the probability of that person getting more and more infections or inflammation. Now, can I microneedle a patient who I just had on tretinoin? No. Remember, you have to observe, what these drugs are saying. So you have to make sure you do a washout, okay? Then we have the acne scar. Why is it that the acne-prone patient and the acne scar patient, we treat at different depths? Let's look on it. This is the skin, epidermis, dermis. The glands, they tend to reside like here. And when you have acne, you have inflammation of the gland because it's blocked. And that inflammation, let's use our head. This is the gland. If we have inflammation of the gland, the inflammation is not going to be just, that lining of the gland. It's actually going to engulf tissue around it. Let's think about inflammation. You get a cut, it's not exactly on, where you've been injured. It's a little bit wider, okay? So that means when you have the inflammation, all of this area will be affected. What is the scar? The scar is actually death and destruction of this gland. So all of this tissue has now died, it's no longer there, and you have a hole, okay? So that means that my needles need to go deeper if I want to touch the bottom of the hole. Making sense? So that's why you're going to notice that there's a difference in depth of penetration. And thin skin, thick skin. You notice that at the top? Right here? What's that all about? Well, it has to do with you being able to assess the patient's skin so that you know how deep to put your needles. Let me give you the trick to it. You treat all your patients as if they have thin skin when you're starting. And I like to treat starting with the cheek because it's normally the area where you can go your deepest level of penetration because it's the thickest skin on the face. And what needle depths are we going to go to? Look at it right here, 1 millimeter. Can't want it easier than that. So obviously this is not problem specific. This is more protocoling the treatment. So if I have a patient with melasma, do I need to go to 1 millimeter? No, right? But this is just for you to grasp how you do the treatment. So look at this. We're going to start at 1 millimeter, okay? Then we're going to move from 1 millimeter and we're going to give 80% of that over this area right here. What I've found is once you approach a bony area on the face, it tends to be more tender and the skin or the fat layer between the skin and the bone is diminished. So that means you will want to decrease your needle depth. So if I'm 1 millimeter here, when I'm going up here, I'm going to be decreasing to roughly 0.8, maybe 0.75, okay? Then from here, I'm going to go up to the forehead. So I move in this kind of motion, okay? When I go up to the forehead, I'm going to start at half of what I did on the cheek, right? So if my clinical endpoint was achieved at 1 millimeter over the cheek, I will start at 0.5 when I start addressing the forehead. Now, when I start addressing the forehead at 0.5, what am I looking for? I'm looking for the skin response. If I do one pass and immediately I see some blood starting to come up, and this patient does not have rosacea, this patient is not on aspirin or any sort of blood thinner, I can very easily know my depth, it's too much. If I have a rosacea patient, no matter what depth you go to, they're more than likely going to bleed. Why? Because rosacea is where you technically have an anomaly and the blood vessels, which should be in dermis, you have a few rogue ones traveling through epidermis, okay? Kind of like sclerotherapy. If you guys have done sclerotherapy, you'd be more abreast with that, that whole concept, right? So look at this. So 1, 0.8, 0.5, and then we're now coming down. So half of what we did here is going to be our benchmark for the nose and to go around the mouth, the lips. Okay? So we're now at 0.25. Going over the jawline, I like to use the same depth as I did for here. So we would be at roughly a 0.8. Okay? When you're coming out of the face, you're going to be doing neck. Guess what? The neck tends to not really have bony prominences. So I would go and do the neck at the same level of penetration that I did on the cheek. And then as we progress down to décolleté, obviously, you know, you could look at doing the same thing. Either the same level as the cheek, or you may need to go a little bit deeper. Then we have our wrinkles. Light wrinkles. Well, light wrinkles, that means your elastin bonds, your hyaluronic acid, your collagen, you have a minimal depletion. Everything's there, but it's not the way we want it to be. So you're getting some sagging, you know. So what do you want to do? You just want to stimulate that process to get them going again. So you don't need to go right down deep. Remember, the whole idea of microneedling is do what's necessary. Don't over-treat, don't be overly aggressive, because that's where you could be going into the realm of complications. Now we have deep wrinkles. What does that mean? Deep wrinkles means that the amount of deficit is now greater. So your level of penetration needs to be greater. Instead of transecting, if this is the dermis, instead of transecting just a little bit, I need to now be able to transect the whole thing so that I will have a greater amount of dissociation of that tissue, and I will have a greater call for your body to reorganize that tissue and rebuild it. That's what this thing is all about. Can you build a new house on the site where you already have an existing house? Not really. You have to get rid of that one and then you go new. So that's what this is all about. It's killing the cells over time to enable them to remove one and replace it with something newer, better, stronger.